everyone. Good afternoon. Thank you for joining us for our first session of the second annual First Fridays with Fairbanks series. The First Fridays with Fairbanks series is made possible by the IU Alumni Association and the Richard M. Fairbanks School of Public Health Alumni Board. The Alumni Association will host live Zoom events featuring Fairbanks School of Public Health student and a faculty member from January to May. Each session will be recorded for individuals interested in the topic but unable to join us. My name is Alycia Felix, and I'm a first-year graduate student here at Fairbanks School of Public Health studying healthcare administration. Today, I'll be speaking with Dr. Joshua Vest, who serves as a professor in the Department of Health and Policy Management. Dr. Vest and I will be speaking about ongoing research pertaining to how social risk factors impact populations, individuals, and healthcare organizations. He will be covering some studies that he and his colleagues have conducted and some of their ongoing work. His work has been funded both by Indiana University and the Agency for Healthcare Research and Quality. Throughout this event, please utilize the chat box below. Clicking on the chat option will open a chat box on either the right or center side of your screen. This is where you should type any questions for Dr. Vest or myself, or to initiate a conversation with other participants. Once you're finished typing your question, hit enter and feel free to either exit out of the chat box or to leave it open to keep an eye on ongoing conversations. We are hoping for robust conversations, and we will be refraining to answer questions at the halfway point of the session and at its conclusion. We'll be monitoring all questions and we'll try to get to all of them. A few reminders about using Zoom. We have automatically turned off your microphone, and we will attempt to keep everyone muted except for those speaking and asking questions. Additionally, this session is being recorded for those who could not attend. We appreciate your willingness to connect virtually. On that note, let's get started. Dr. Joshua Vest is a professor here and vice chair of the Department of Health Policy and Management. He is also a scientist and with the Regenstrief Institute and a director of the Fairbanks School of Public Health Center for Health Policy. He is a health services researcher with an interest in organizational determinants and effectiveness of health information technology and systems. Please join me in welcoming Dr. Vest.
Howdy, y'all. Let's thank y'all for joining us, and at least thank you for setting us to go here. And let's make sure you are looking at the right screen. The answer is, are you or are you not?
It pops in and out from from your full screen to the multiple slide screen.
Which one am I on now?
Multiple.
This is the wrong one.
Wrong one. There we go. All right, here we go.
That's a good one.
First guess was the right guess, and I was wrong the second time. All right, should have gone with my gut. So thanks for the opportunity to come and talk about social risk factors and some of the research me and a bunch of colleagues are doing here at the school. I am going to cover kind of a little bit about social risk factors, what we're trying to measure, some of the issues around it, some of the challenges, particularly facing healthcare administration, healthcare administrators and organizations. And then we're going to take a little bit of a break and we'll move into some of the activity and research we're doing. Hopefully this all kind of builds together cohesively. So first, this is the educational part. Let's kind of put some vocab out here. Social determinants, social factors, and social needs. Social determinants of health is the buzzword. It is something that is everywhere. And if you Google it and you talk to folks, everybody says social determinants of health. Social determinants are really those conditions in which people are born, live, grow, work, and age. It's really the environment that is shaped by money, power, and resources. So when we talk about determinants, we're at this very high level about the areas and the environments in which individuals, and in our particular interest, patients find themselves. Factors are what we could consider like risk factors. They're the individual characteristics that are non-clinical, economic, contextual, psychosocial, that are associated with poor health. So when we talk about social factors, it's pretty much anything that is not medical that's related to health, that's known to cause poor health. And then when we get to social needs, that's the immediate issues or acute situations that individuals face. So we have this kind of hierarchy level of determinants of the areas in which people live that influence their health, that's their social conditions, the factors of those individual risks that they have for poor health given their characteristics, and then needs as an acute instance of those risk factors popping up. Now, why do I mention that? Well, as I said, the buzzword is actually social determinants. And that's what everybody says when they talk about social risk factors. Everybody says they're doing social determinants. However, truthfully, what they're really measuring and what most healthcare organizations are intervening on, and in some ways, many policymakers as well, is really social factors. They're dealing with the individual level. Very few, there are examples, of course, but very few healthcare organizations are actually changing resources, environments, power, dynamics, those kind of things. People are most dealing and really measuring at the social factor level. However, they're probably really only dealing with when patients have needs, when it's an acute issue as well. And I just mentioned that out there to kind of like set some of the language. The truth is, you know, that determination and that those distinguishing characteristics between these different kind of words is very academic, and words are important to us academics. But in truth, when you say social determinants, people are probably talking really about those lower areas of factors and needs. So when we talk about social risk factors, what kind of things are we talking about? Well, broadly, we're talking about socioeconomic status, cultural context, social relationships, and really their community context. And these are really, really prevalent, high value issues facing healthcare organizations and the patients they serve. For example, like you think about America and what we are as a country and our standard of living, but more than 10% of our population has food insecurity, right? That they have challenges eating healthy and sustained on a regular basis. That has a ton of health issues. You know, we do have a lot of individuals who have graduated high school, but not everybody has. And higher education is associated with a host of better outcomes. 15% of the adult population lives in poverty, right? We do have fairly low employment right now, but employment still is an important avenue to getting insurance and coverage and connectivity. Social relationships. 1 in 9 adult men face a risk of incarceration in their lifetime, which is really huge. Part of the COVID pandemic, we saw social isolation, dramatic issue about not being able to connect with individuals. That's premature mortality associated with depression, lack of physical activity. Very, very common. For healthcare organizations, we serve a very diverse population. 1 in 5 Americans speak a language other than English. About 3% of households have actually very limited English availability. Outside of language, the US has relatively high levels of low health literacy. About 1 in 4 adults just have challenges understanding healthcare instructions, healthcare education, and directions, and that has a lot of negative effects. Then we also see things like transportation barriers, which cause delay, and then we have just a host of things that get exposed to violence, which is very common in the country. So these are all things that are just really important, that we know intuitively important. In addition, really powerful and influential organizations say that it should be important too. The National Academy of Medicine had a large report talking about the value of understanding social risk factors and incorporating them into measurement strategies. CMS is starting to pay for and require much more collection of social risk factor measurements. The American Hospital Association is on board with measuring social risk factors and document them as well. And they're fairly common. Some surveys estimate that nearly 9 out of 10 health systems do some sort of social factor screening, so it's pretty widespread. Reports of individual physician practices put the number a little lower. They're talking around about 16% of individual practices do it, but it's not something that is completely unheard of. A lot of people will be doing it. Now, that's kind of the content area, like what is social factors? But what I'm largely interested in is how we measure them. And there's been 3 primary ways healthcare organizations have measured social risk factors, gone out and actually collected that information or screened patients on these characteristics. The first is surveys. They got a lot of positive things, right? They're widely used. It's pretty easy to say, hey, give people a survey. That makes sense. A lot of these survey tools are built into EHRs. If you're an Epic user, Epic has their very well-publicized wheel that shows people their risk factors, and there's questionnaires out there for it. And a lot of these questionnaires are in multiple languages, so they're widely implementable. That's all good. On the limitation side, nearly every survey out there used to measure social factors has actually not been psychometrically evaluated. And that what means is we don't have reliability and validity on them. So we're using them as screening tools with unknown validity and reliability characteristics. And you may say, well, that's just social risk factors, but the challenges are these are still sensitive issues, and a poor tool could actually create more challenges in terms of unnecessary services. There are workflow issues and burdens with giving patients one more survey, particularly in this high demand for care period. Just asking more and more to fit into workflow and asking patients to complete one more thing gets a lot of pushback from healthcare organizations. And there's a risk of response bias. A lot of patients are not universally screened. And I'll tell you why this is such a critical one. This isn't a social risk factor, but this is an example of the problem of selective screening for any condition. This came from example, it's up there on the slides, but they went and did a study this was out in New York State, and they looked for women who consented to be screened or women who refused to be screened for cardiovascular disease. And you see the overall death rate on the left for New York State. Among the women who choose to be screened, and then the women who refuse to be screened, you have substantial different mortality rates. And this isn't the mortality rate of like, oh, because you didn't get screened, bad things happen. This study is really showing that actually the people who consent to answer questions and participate in screening for health issues are very different than the people who don't. And that's one side of the equation. There's been other studies that document that healthcare organizations actually just may not screen some people because they think, quote unquote, they look like they don't have social risks. Or there was an interesting study out of Utah that said basically, hey, this person has private insurance, therefore we don't think they need to be screened for any social risk factors. We only bother screening people when they have, are uninsured. And yes, uninsured patients may be at higher risk for certain social factors, but social factors cut across a broad area. And once you start doing that, it leads to a whole bunch of problems in trying to use that data for decision-making. So the other option you could go with is say, you know what, let's use our textual data, our natural language processing. Providers have been documenting social history in notes for probably 100 years now, at least decades, right? That people write these things down in notes. We can just pull them out of the notes. It can be automated into the backend processes. Nobody's got to ask any other questions. There's no surveys. There's no anything. That's very promising. However, it's still very cutting edge. We'll talk a little bit in one slide, some of the stuff we're doing on NLP, but I'll tell you, it's actually really very challenging to create the dictionaries and create the algorithms to find transportation barriers. It's not as simple as it might sound. The other challenge is NLP is very good at like looking for things to exist. But once you start trying to do temporality of like things coming off and on, or housing stability being okay to changing to not okay, it gets much more complicated over time. And there's still a selection issue of you still have some individual, a provider, a nurse practitioner, MA choosing to write something down, or a patient choosing to share it. So there's still a selection of who actually shows up in the notes. Also, just not everybody's able to do this yet, which is a challenge. What we've been doing in collaboration with the Regenstrief, this is actually part of the Addiction Grand Challenge stuff that we've been working on, is we've been developing NLP algorithms to go through the notes and look for presence of housing instability, financial insecurity, and other issues. And I'll show a couple that were recently presented by one of our doctoral students at AMIA. We've gone through and done a test set, a training set, and then the bottom is our final validation set where we ran through and predicted our models on a brand new population, and we had individuals go through and read through chart abstract, are they true or not? And we can actually have a positive predictive value about 94% for housing instability. That is, if the thing shows up positive, it's about 94% likely that the person actually does have housing instability, mentioned in the note. Financial insecurity is a little better, about 97%. So we're very excited to be able to start to use these tools to help understand and measure. There's one other way that we could use, and that is ICD10 codes. This is structured data, which is phenomenal. Everybody knows ICD10 codes. Everybody codes other stuff. And ICD has social factor codes. Let's put those in there. A lot of these are built into the EHR and practices, and they could be really easily used. People just click and say, yeah, here's this diagnosis, just like any other diagnosis. The challenge is these are dramatically underused. This is some work we've done with one of our health systems locally, looking at, we ran out a survey and asked patients on financial insecurity, transportation, food insecurity, housing instability. You can see in red the percent of patients who screened positive based on their answers of the survey. The percent that would have been positive per ICD-10 code is way at the bottom in the blue. You're seeing, things like 45% of the patients have financial insecurity, but ICD-10 codes for financial insecurity only around about 5% of the time. So it's dramatically underused. And I'd actually even say this, you may say, wow, that's terrible. This actually is much better performance than many other studies nationwide that show that it's even worse than this. The fact that we're getting around 5% and higher is actually pretty high for the use of ICD-10 codes. It's just not that common. So before I start talking about some of the other activities and research we're doing, I'm going to stop for a second and pass it back to Alycia.
Yeah, so we did have a question come in. If anyone else has questions, please feel free to use the chat box. You can jump on with your microphone as well. We did have a question from Joyce Nut, and she asked, what are some of the issues that prevent surveys or tools for being psychometrically evaluated?
So psychometric evaluation is actually fairly hard. I mean, if you think about it, you have to have a gold standard, what we would call a gold standard, right? You have to have the ideal way is you have to have some sort of independent measure that determines truth. So if you were testing any kind of diagnostic study, you would have your screening tool, but you would have some independent evaluation. And that independent evaluation creates costs, creates burden, creates challenges. The other issue, that's one. The other issue is to get a better, more robust tool. Generally, it requires more questions. That's one way to do better, is just simply increase the battery of questions. It's possible to get a highly valid and highly reliable tool with simply 2 or 3 questions, but it's much more challenging. A lot of these social factors are very multidimensional, and so it's hard just to simply ask one question. So for example, housing instability. Housing instability ranges from homelessness, which is the most street homelessness, which is the most acute instance of housing instability, but then there's more what we would consider hidden homeless, people who are couch surfing, people who are living with relatives, then even to the extent of people who are fearful of being evicted or having trouble paying their rent. It's very hard to have a small set of questions answer that. And so that just makes the determination much more challenging. Also, too, a lot of organizations, I said health systems, the majority of them ask some sort of screening questionnaire. Most of those screening questionnaires are actually fairly pragmatic, developed. People have a pet interest or priority or something they know from, say, a community needs assessment that's a big need in their community, and then they are very selective on what they do. So they'll take a question here, take a question there, take a question from those. And that's how mostly they get developed. And so it's not like it's been nefarious, it's just been pragmatic, and it's challenging to do these very structured, tested tools. And the problem is you don't know how accurate they are out there in the field once they're in live, but that's kind of the challenges.
Thank you for that. Also, another question came in. How can healthcare organizations better support their providers to increase resource utilization that screen for social risk factors?
Give that to me one more time.
How can healthcare organizations better support their providers to increase resource utilization that screen for the social risk factors?
So I think one of the things about supporting providers is for the organization, and this is my perspective, for the organization to know who's going to be acting on social factors, right? There are lots of surveys out there of providers, and universally, this is generally the case, universally providers are in agreement that they're important. They understand that it's a major challenge to why they come in. Like, this will date me, right? If you go to a provider and ask them, what is the most difficult case you've ever had, or tell me the most challenging recent patient you had, it's not going to be some kind of house kind of like rare disease that they had to do. No, it's going to be Mrs. Smith knows she needs to take her medications, but she just can't because she can't afford to go to the pharmacy, and she can't afford to pick them up, and she can't leave her husband behind because he has challenge. Those kind of, it's always the social is a big driving thing. And so there's a big impetus to address it. The challenge is, from my perspective in administration policy, physicians are not the right people to be dealing with that, right? That's not what they went to school to train for. It's not their skill set. That's a very different type of set of interventions and longitudinal activities. And so for an organization who really wants to support it, they're going to have to build in those wraparound services. They got to build in the wraparound services with case managers, social workers, health educators who can handle that and deal with that very different set of skills and different set of knowledge base. And that can be done internally or it can be done externally, but that has to be wrapped around for that. And it has to have the processes set up really well for a provider to say, Alycia, I see that you need some assistance in fill in the blank area. Let me get you to the person who can help with, right? Like that, treat it like a regular referral to a specialist, because that's what that person is. They can have that specialized knowledge and they can handle it. But if you put it on the providers to address it, then it becomes much more challenging.
Thank you for that answer. We have one more comment from Mr. Bill Tierney. He stated, I'm betting the ICD-10 codes for social health needs are not being recorded because physicians and healthcare teams don't see them as medical problems and therefore not their responsibility. What changes in primary care would you recommend to include social care into primary care as the NAM called for? Should physicians be educated to do it, or should there be social care providers included into the healthcare team? If the latter, how might it be paid for?
So yeah, I think that the last thing, Bill, is what you brought up as the most important thing. Somebody's got to pay for it, right? Like unless people pay for it, it doesn't get documented, right? Unless it's part of the billable stuff. And I think some of those things are starting to change. The fact that social workers can bill for some of their hours now is an important thing. In Medicare, some of that billing for social workers. I see Dr. Yeager on the call, who's done quite a bit of stuff around case conferencing, and that can be billed for as well, that deals with social workers. And so finding those avenues where people can bill will then drive some of the documentation. I mean, we know this, right? Like if there's no payment for billing codes, people don't put billing codes down, right? That's just the way it works. And so I think that has to be a reimbursed aspect for it. And that could be done any of the ways that Bill talked about, like putting in social workers and having them as part of the care team and billing through that, or using those bills to refer to social workers who eventually get paid for their services.
Thank you for that. Another question, again from Joyce Ned. Do you know if there's been a decrease in social need referrals during the COVID-19 pandemic, given the increase in number and intensity of caseloads for providers?
No, that's a good question. I don't know about the level of it. I know there's been a significant spike in social needs associated with the pandemic, particularly around social isolation and the behavioral health needs. That's not totally social. That's getting a little to the outside. I think one of the challenges is that the level of referrals actually has somewhat of a cap, right? We talk about, send patients to community-based organizations or partner with community-based organizations. The social service network in this country has a finite carrying capacity. It also has a very real financial set of constraints that they operate on very thin margins or deficits as charities. And so therefore, there is a limit that may have already been exceeded prior to the pandemic that could really go on. So that's a long way of me saying, Joseph, I don't know, but I guess it was probably high to start with, and it's probably stuck high would be my guess.
Thank you. And then for our last question of this little session, Bill asked, what changes in information flow are needed to treat social care referrals the same way as referrals to specialists?
So I think, Bill, it's going to be closed loop referrals, right? I think that's what people are looking for. If not a clinician, don't even play one on television, right? But like, if you're accepting care and making a recommendation for a particular service for a patient, all of a sudden you have a vested interest and a desire. You're not just doing this willy-nilly. You have a vested interest and a desire to know that this actually was effective, met the patient's needs, and was utilized. From an administrative standpoint, we want to know that the partnerships and the referral networks that we do actually get utilized and successful. And that doesn't happen unless there's bi-directional communication. That is, Bill sets up and says, you know what, Alycia, we're going to refer you to, say, this food pantry. There's a way that message with the appropriate information on you goes to the food pantry. And then there's a message that comes back to Bill in the health system that says, oh, by the way, you actually went there and got the services you need, right? That's a very, very hard lift on a lot of ways. But it's a technological lift. That's a giant governance and policy lift. But that's really, truly where things are moving towards. And we have to be to really kind of like get that closed loop system to really show, yes, we're dealing with social services, we're referring to them, and they're getting them. And I know, Bill, that as an asterisk here, we'd say that like closed loop referrals to be like specialists, and that not every specialist is on a closed loop referral system already anyway, right? Like the transition from primary care to specialty care isn't seamless and back, but it's obviously much more further down the line than to social care.
Thank you for that. Thank you all for the great questions and discussion. Please don't refrain from asking any questions. We will have another question session at the end of this presentation. But Dr. Vest, you can go ahead and proceed with the rest of your presentation at this time. Thank you.
Try again and make sure I do this right. We're good, right?
We are good.
We are good. Excellent. All right. So this now kind of we talked on stage about like what you can do and measure, and this sets the stage for our current research. And how can we best measure social factors? And we said, well, hey, we can do surveys, we can do NLP and text, we can do ICD10 codes, and I'm interested in all of those things. Like, how can we use those to measure? But I'm also going to show you secret option number 4, which we didn't talk about. Secret option number 4 is what we call computable phenotypes. And this is something new and something that I'm kind of jazzed about and I think is really fun and exciting and potentially useful. And I'll explain what these are. So a computable phenotype is a representation of patient conditions or characteristics that we can get out of EHR data by combining a set of variables and logical expressions. And the simplest way to think about this is by example. So think about diabetes. We all know that individuals who have diabetes, right, may not have a documented ICD10 code in their medical record. They may know they're diabetic, they may have diabetes, but there's nothing that says they're diagnosed with it by code. So if we were just to go query all the codes, we would be short. But we can say, you know what? You may not have a diagnosis code, but if you're on insulin, and you've got abnormal labs, and you've got some other medications that only get prescribed to diabetics, we're pretty sure we can use those other things to find people with diabetes, even if they don't have the diagnosis, and really kind of create that population cohort based on those characteristics. And people have done this for a huge number of clinical conditions. Diabetes is one of the foreruns, but there's the runs around dementia, behavioral health, lots of different cancer diagnoses. These exist in clinical things. And the idea is the EHR data is good, but not perfect. And if we think about and be imaginative and creative and use what we know about data and how things get coded to find everybody else. And so that's what we're going to try. We are going to say, how can we best measure social factors? We're going to take the 3 traditional measures and we're going to do our new kind of computable phenotype, fancy machine learning, AI, buzzword compliant kind of stuff. So what are we doing right now? Well, right now we are out collecting validated surveys. Joseph had asked a question about like, how do you do validation effect? And one is you say you got to have a standard to compare against. You've got to have that kind of independently measured knowledge to say, yes, this person has this condition or meets this qualification. We're actually right now doing 1,500 surveys of ED patients, and we're doing 3,000 surveys of primary care patients here and in Florida. And we're giving them independent tools that can actually, and these tools have been validated. So when somebody answers and says, yes, I have housing instability, we're very comfortable that they really do. We're using tools that have been assessed in that way. And so those are out in the field. So I'll give a couple little highlights just so you can get a feel for what our community looks like. The ED surveys are actually out in Eskenazi, and I'm only going to talk about the ED population right now. But the primary care is going to include IU Health as well. So here's a simple question. Within the past 12 months, have you worried that your food would run out before you got to buy more? And you can see in our ED sample already, 1 out of 10 individuals says that's often true. And in fact, according to the scoring criteria of this particular tool, anybody who says sometimes true or higher would be considered at risk for food insecurity. And so all of a sudden you're looking here and saying half the population in your ED is at risk. And that's a giant need. If we were to look at a time when people may not be able to pay the mortgage on time or rent on time, which is one of the questions around housing instability, we see it's 1/3 of patients walking through the door at the ED. And if we ask another question, do you have current legal issues, which we're looking at the ED, we're getting 10% of the population. And so as we think about these things, that's a lot of different needs that can turn around and complicate the delivery of care. All of those things can make care more complicated, more expensive, the likelihood of bouncing back to the ED much more common. And so these are all potential areas for the healthcare organizations to intervene on and to help address social needs. And there's a lot of demand out there, clearly. So then what we're next doing is, or kind of not next, but kind of as part of this project is, we're starting to say, okay, how could we build and measure things for these phenotypes? How can we take data? What do we need to have? What do we need to use? And so we convened, a colleague and I convened an expert panel where we went through a couple round Delphi process where we asked this expert panel start talking to us about data elements that we can use in phenotyping. This paper's in press right now, and we said, just tell us what we can use. How can we measure it? And this panel came through with just a huge number of ideas, right? So looking at things that are in the EHR that you say, EHR, that's the medical record, that's the health record. Well, there's a lot of stuff in there that's about social. Changes of insurance over time, looking at the financial data around like, did somebody have $0 billing, or did they pay by cash, or were they referred to financial counseling? Have they been referred to SNAP or TANF? Did we have referrals to food pantries? Looking at housing, we can look across longitudinally over time and say, how many different places has a person lived in the past 12 months? That's a very strong indicator of instability. Or how many different times have they changed their telephone number? Or do they have an address of a known homeless shelter listed in their EHR? We can look at things like across emergency contacts. Do their emergency contacts live in the same state, right? Do they have one? Are they missing information, right? That talks about social relationships. We can look about where patients were admitted from, where patients were discharged to. or got their services to talk about incarceration history. There's other things we can do around how people got there for transportation and a whole host of stuff that we can get out. And so this paper was really, and this research was really looking and saying, okay, what are these building blocks we're going to use when we go to start building these phenotypes? And we collected a whole bunch of stuff. I also want to talk about something that I think is really important to me and my colleagues who are working with it, and also this panel, was the risks and things we need to pay attentive to. And they talked about this, right? Like, we have to be very thoughtful in any time we're measuring and talking about populations, that we have to account for the fact that discrimination exists. Certain populations just don't have access to the same level and extent of services based on discrimination and access to care issues. And so we have to be thoughtful about how those things come in and play into whatever kind of measurement strategy we have. And we do not want to continue to perpetuate those problems. Same thing, we know that some stuff is just biased. There is data out there that could be used, but we know is really, really bad. So for example, some health care organizations have linked data to credit scores. I've talked to a couple of researchers who have been looking at that. Credit scores are incredibly important measures. They're also known to be exceptionally biased against certain race ethnicities. And knowing what that data can do and how it affects choices in our measurement strategy is really critical, because again, once bias comes in, it's really hard to get out of any kind of measurement strategy. So you've got to think about those on the front end. We also thought about differences between adults and kids. So far, everything I've been talking about is largely about adults, right? Kids have social risk factors too, but the challenge with measuring kids' social risk factors is it's really driven a lot by the family, parent, guardian, grandparent, their social risk factors cascade down to the kids. So measurement gets really tricky, but thinking about how we measure across different populations is very important. And lastly, some of the things we didn't mention is, does somebody just live in a low income area, or is somebody in an area from high unemployment? Area measures are very important. This actually gets to what is the social determinants level. These are very important things, but it gets really hard to use those for individual prediction, right? I think everybody on this call has probably heard the ecological fallacy at some big mentions at some point, and that's very true. Just because you are living in a high income area, you actually may be low income. Just because you live in a food desert, you actually may not have food insecurity. It gets very hard to make those generalizations, so they have to be very careful with those. So that's stuff that came out of all of our kind of expert panel as we start to come forward and build. And lastly, I've already mentioned that we've been working on natural language processing tools to pull out housing, financial, unemployment, incarceration history, food insecurity. We've been pulling those out with our partners over at Regenstrief, been doing manual chart reviews to actually make sure they work. And our goal is to have that run out and be used for health systems to say, yes, this is available to you. Now, putting all of that together, what are we trying to do as we move forward into the future? Well, one, what we're doing first is we're building predictive models for social risks in the ED. We're saying, can we use all of our aggregate data in kind of a phenotype kind of way to predict who needs and who has social risk factors in the ED? We're then going to move into very qualitative work and say, okay, assuming we can build these models, or alternatively we can't, and we just have to default to asking by screener questions, what do patients and providers think about it? There's a lot of screening in outpatient settings. The ED is very different. And what do patients expect and what do providers want to do? We also want to make sure these perform well, and we're going to be checking for bias like gangbusters to make sure that they're fair predictors. The other work we're doing is really very psychometric. We are collecting our NLP, we're collecting our surveys, we're collecting phenotypes, and then we're doing a nerd battle royale, right? We're going to compare them across each other. We're going to do the validity and we're going to do the reliability and see which one actually does best. We're then going to say which one does best in predicting future utilization, which healthcare organizations would be dramatically interested in. We're then also going to look across them and say which one is being fair and which one is biased. And so that's really kind of the work we're doing. We're collecting all this information. We're thinking about all these measurement strategies in order to figure out which one of them, or truthfully, which combination of them is going to be the most effective for researchers and for healthcare organizations. I do have to mention this, a whole bunch of stuff in here was mentioned and supported by NIH. Some of this work is not listed on here, is also supported by HRQ, but I had a bunch of people who were contributors and helped out a lot on this, and I want to make sure that I thank them as well. So this is the point where I send it back to Alycia.
Thank you for your presentation. This concludes our presentation, but if anyone has any remaining questions or comments that they would like to address, we would like to have a discussion time for that. You can utilize the chat box or jump on with your microphone. We do have one question from Ms. Antoinette. Could this research assist health administrators as they make decisions about workforce concerns and strategies to combat and mitigate bias in employment practices?
Oh, interesting. So so we're actually adopting our bias assessment methods actually all come out of computer science and consumerism, right? Like this is healthcare. We're very aware that biases arise in our processes. We're very aware that biases exist in care delivery. We know that these things exist, but all the tools we're actually going to use are all have been adopted from the kind of people that you've mentioned, right? That kind of place that know how to check for biases. That's where we're adopting all of our tools. But I think this, hopefully what we can do is really use this for measurement for any population. And I think what Antoinette is kind of hinting is, we talked about a patient population, but a large employer, may be responsible for their own or accepted risk for their own patient or their own employees as a population, right? That could be applied there. I've mentioned health systems. This could be handled by a payer as well. Anybody who's interested in understanding what's going on in the group of patients that they're accountable for, these measurement strategies are appropriate and can be leveraged for them, right? And so I think that's where like that setting, any of these things could be fit to that. We just got to figure out which one's the best.
Thank you for that answer. Do we have any other questions? We did have some comments from Mr. Gerardo. I'm glad making clear between differences of social determinants of health and factors. And then Lucas wanted to thank you for spreading awareness and educating today. Any other questions or comments today? Do have one, excuse me for not saying your name correctly. Musu asked, what are some of the reasons for the dramatically underutilization of Z codes? If they are part of intake, will that make a difference?
So I think the why are they not used? Nobody pays for them. I mean, that's the big underlying reason, right? Like that's there's other reasons, but like that's 90% of it, right? That actually may be 95% of it why people don't use it, right? That's just how it is. Places have done better. I'll give you an example. So a couple of the hospitals in Kaiser's system as an academic practice built in automatic Z coding. So they would administer a survey to a patient, and if the patient answered the survey based on their answers, it would automatically populate the Z codes. And that did a dramatic, as you would expect, dramatic uptick of their Z code documentation. The problem is it's still inherently limited by their ability to deliver surveys, right? And that's so if they didn't deliver a survey, there was no documentation. And there's lots of reasons why people don't always deliver the survey, just given workflow burdens. But there are ways to increase it on the back end like that. But the biggest thing is always going to be you just got to pay for it.
Thank you. And then one more question from Bill states, how might your computable phenotypes be used in everyday clinical practices?
Yeah, so I think this is fundamental for risk stratification, right? Like, so this is Alycia probably heard me say this way too many times in class, but like that's the whole point, right? Like, so when you think about managing this population, you've got to break it down and match people to what they need, right? Like you've got to be able to say this set of patients needs this services, this set of patients needs this services. And I think that's where phenotyping can come in. It's an effect, it could be, it could be, right? And maybe it's in combination with NLP, maybe it's in combination with surveys, but this idea of how do we actually best measure and identify patients for who needs what? And you can call it risk stratification, you can call it patient segmentation, right? Whatever you want to think about it, but it's really this idea of how can we slice and dice the population and get people the services they need? Because if we're trying to do scattergun and broad, that's just not efficient. We're going to miss patients we have, and the health systems just can't, right? Like they got to be able to target and get to the right people. And I think that's what their application would be. If organizations are being pushed more and more to intervene on social risk factors, they're going to have to be targeted and get to the right people, because that's a kind of the appropriate thing and the ethical thing to do, right? Get to the right people, but also too, it's the one that's going to yield them the benefits by hopefully saving costs later on down the line.
We have another question from Dr. Stone. Do you think there's a role for a community health, or excuse me, CHW or a patient navigator to help collect this type of information while people are waiting for providers?
Yeah, that's a lot of the places that are trying this. That seems to be the approach that goes through. You use an MA or another staff member who's doing this as part of the screening, part of the intake before they get to the NP or the the provider to see. Then that seems to be it, because that seems to work well in the workflows. The surveys of physicians prefer not to be the ones to administer these questions. They tend to prefer to have the other staff do it. And so that seems to be a way to do it. Although it is that does generate cost, right? It's a body asking extra questions above and beyond a lot of the questions that get asked in check-in anyway already, right? Like verification of insurance and then all the other measurements and stuff that goes on. So, but that's where a lot of people have moved.
Great, thank you. Do we have any remaining questions? We'll give it a little second if they want to pop in. Either way, thank you all for participating today. This concludes our discussion. Thank you, Dr. Vest, for elaborating on just how important it is to accurately discern between social risk factors and how it impacts not only individuals, but the way healthcare personnel and organizations can better support the populations they serve. I hope you all will join us on February 4th at 12 p.m. for our next session of First Fridays with Fairbanks. IUPUI student Alexandria Murphy will moderate our next event alongside a fellow faculty member within our Fairbanks department here at IUPUI. And then we did want to mention, Amanda stated that this recording will be available if you want to check out our social media or any communication. We should provide you with the link once that's available. So thank you all for joining.
Thank you, Alycia.
Thank you, Josh and Alycia. That was wonderful. I'm going to